So I invite you all to sit back, hopefully with your favorite beverage of choice, relax, and enjoy tonight's program. Next slide. At this time, I would really like to thank our generous sponsors. Without their assistance, events like tonight and activities offered by CANIBD would not be possible. Our silver sponsors for this year are AbbVie, Pfizer, and Takeda. I understand there's a number of our sponsors in the audience this evening, and I'd like to welcome you all. Next slide. At this time, I would like to welcome Kate Lee. Kate is the VP of Research and Patient Programs at Crohn's Colitis Canada, and she's going to speak to the CANIBD group this evening. Kate?
Thanks, Jen. Good evening, everyone. On behalf of Crohn's and Colitis Canada, I'd like to welcome you to the virtual CANIBD conference. Crohn's and Colitis Canada's promise is to cure Crohn's disease and ulcerative colitis and to improve the quality of life of everyone living with these diseases. Recognizing the key role that IBD nurses play in improving the quality of life of IBD patients, Crohn's and Colitis Canada has been supporting CANIBD since almost the beginning of the inception of CANIBD. Our partnership has grown every year, and we look forward to strengthening the partnership. On a personal note, since joining CCC, which was in 2017, and working closely with the steering committee of CANIBD, I must say I have developed an awe of all the IBD nurses in seeing their tireless dedication to their profession and to their patients. So I'm especially proud to be representing CCC tonight to welcome everyone to the CANIBD conference. So with that, I'm going to hand over the virtual podium back to Jen.
Thank you, Kate. So some of you may be new to CANIBD, and just to kind of briefly recap, we are a community of practice within CSGNA, and as Kate mentioned, strongly supported by Crohn's Colitis Canada. Our vision has been to ensure people of all ages living with inflammatory bowel disease in Canada are receiving high quality clinical nursing care within a multidisciplinary team. Next slide, please. CANIBD has a steering committee of nurses from across the country who volunteer their time to help fulfill our mission and to promote IBD nursing, education, research, and are also strong mentors to our new and novice nurses entering the field of IBD. Next slide. Please welcome your CANIBD steering committee. Next, I would like to just briefly review the agenda for tonight's program. We're going to start off with our nursing forum, which has been an annual part of our program. It's a brief CANIBD year in review where we will welcome our nursing fellows as well as our research grant recipients this year. We're also going to have a short program commemorating the Year of the Nurse and the Midwife. And then we will be moving forward with our plenary session where we will be hearing from our international panel on IBD nursing yesterday, today, and tomorrow. We're then going to wrap up the program this evening with the presentation of our IBD Nurse of the Year. Next slide. So with the circumstances surrounding COVID, a number of our programs have had to go virtual. So CANIBD has elected to provide a webinar series that started earlier this spring and will be followed through to the spring of 2021. We started in May of 2020, where IBD nurses, especially those in CANIBD, participated in a COVID-19 webinar in collaboration with Crohn's Colitis Canada. We then went in July of 2020 with a talk sponsored by Pfizer on treating iron deficiency anemia. In September of 2020, we then had a talk provided by Takeda on Let's Talk About Sex, and we had presenters Kay Grevson and Lorraine Grover, who did a fabulous job on that evening. And then lastly, we just wrapped up a partnership program with AbbVie Canada. It was a nice summit where we heard from Elizabeth Martin on hepatitis C and liver considerations in IBD, Karen Frost, who spoke to us about IBDisc, and Inez Martinovic on nutrition in IBD. We're working at having all of these webinars on our website, so stay tuned for those. Next slide. I also wanted to briefly remind everybody, I may have gotten a little bit lost in the spring during the onset of COVID, but CANIBD did prepare and release 2 new teaching tools regarding biotherapies in both Crohn's disease, and next slide is ulcerative colitis. These are now available on our website, and I encourage you all to take a look at these tools. These are geared towards nursing and other healthcare professionals in providing the different options that are available to our patients in clinic. If you would like to take a look at it, and if you have any comments or feedback, we're always welcome to hear that. I also don't want to forget our vaccination guide for immunosuppressed patients with IBD. This was created by Karen Frost and Melanie Watson, who did a fabulous job. And this is a tool that I know I use quite regularly, and I hope you found it helpful as well. You can also find this on our website. So now I'd like to move on to share with you our CANIBD Nursing Fellowship Program. CANIBD provides fellowships and grants to IBD nurses across the country in order to increase nurses' access to learning opportunities and capacity to engage in research. The CANIBD Nurse Fellowship provides an educational and mentoring opportunity to new or early career IBD nurses through a consistent and structured fellowship program in selected IBD clinic locations across Canada. Fellows participate in a 1-week on-site preceptorship with an experienced IBD nurse. A second week at the fellow's employment site may also be facilitated to allow for additional mentoring with the preceptor. Due to COVID-19, unfortunately, we have had to suspend the 2020 IBD Nurse Fellowship Program. But tonight, I'd like to introduce you to one of our 2019 fellow recipients who was able to complete their fellowship this year. Nicole Leger participated in the fellowship program with Phelan Kelly, who is located in Halifax, Nova Scotia. Nicole tells us that through her fellowship, she learned from a variety of experience. She learned from a very experienced preceptor, learned ways to optimize her clinical potential, learned to transition patients from pediatrics to adult care, learned from the nurse to patient dialogue, and also learned from IBD specialists from her preceptor center. So congratulations, Nicole. We look forward to seeing you out there, and hopefully we can bring you back another year and you can present a topic for the CANIBD program. I'd also now like to announce this year's CANIBD Research Grant recipient. Next slide. I'd like to congratulate Noelle Rohatinsky, I hope I pronounced that right, Noelle, on her research grant approval. And she's going to spend a few moments discussing her research with the CANIBD group. Nicole?
Good evening, everyone. Thank you so much. I would just like to acknowledge my thanks and appreciation for being the award recipient. It really means a lot. So thank you to CANIBD and Crohn's and Colitis Canada for this award. Thank you also to my co-investigators who are amazing and who are all here tonight. So thank you to them as well. The purpose of our study is to gain a better understanding of perceived quality of life and care experiences for older adults with IBD. And we all know that's one of the largest growing age groups with IBD. In terms of our objectives, we are going to assess quality of life and chronic illness care in that age group, and that will be through a survey, an online survey. And then we are going to explore their care experiences using one-on-one interviews. Next slide, please. In terms of who we are looking for specifically, we're looking for English-speaking older adults at age 60 or older who have been diagnosed with IBD at any age. And these individuals can participate in the survey and the interview, or one or the other. And as soon as we receive ethics approval, we will send out our study poster, a letter of invitation, and the survey link through the CANIBD Nurses Network. And we would love it if you would be so kind to share our study information with patients that you see that might fit the criteria. And if you have any questions, or if patients have any questions, they can contact me directly. So thank you so much. I really appreciate it.
Thank you, Noelle. Congratulations. And we do look forward to hopefully hearing back from you next year with some updates on your research. Okay, next slide, please. So in honor of the Year of the Nurse and to showcase the impact IBD nurses have had on their patients, CANIBD filmed a series of 5 short videos. These videos showcased 4 patient stories. I encourage you to take a look at these videos on Crohn's and Colitis Canada website, and hopefully you or your patients may find them helpful. Okay. I want to take a few moments next to recognize and celebrate the critical contribution that nurses and midwives make to global health. In 2019, on the 20th anniversary of Florence Nightingale's birth, the World Health Organization declared 2020 the Year of the Nurse and Midwife. According to the World Health Organization, nurses and midwives play a vital role in providing health services. These are the people who devote their lives to caring for mothers and children, giving life-saving immunizations and health advice, looking after older people, and generally meeting everyday essential health needs. They are often the first and only point of care in their communities. The world needs 9 million more nurses and midwives if it is to achieve universal health coverage by 2030. That's why the World Health Organization designated 2020 as the International Year of the Nurse and Midwife. Not only was the WHO campaign developed to celebrate the role of nurses and midwives play in providing health services, it was also to establish and highlight the challenging conditions nurses and midwives often face in their practices, to advocate for increasing investments in nursing and in helping improve capacity in midwifery workforce. No one could have predicted how fitting this declaration would be in light of COVID-19. Next slide. I'd like to share a short video with all of you that was prepared by the World Health Organization. I know this commemorates the International Day of the Nurse. However, I thought it was really fitting to share with you all.
Today is International Nurses Day, a time to celebrate nurses who are the backbone of every health system, whether it's performing essential services or responding to a crisis. We celebrate them today, but we depend on them every day. Nurses are on the front lines of the COVID-19 response, from community clinics to intensive care units in hospitals. Today, we must take time to honor the nurses and all health workers who have lost their lives during the COVID-19 pandemic. Earlier this year, we launched WHO's first State of the World's Nursing Report. The report shows the world is facing a global shortage of 6 million nurses to achieve and sustain universal health coverage, especially in low and middle income countries. We need to support these countries to expand nursing education and create nursing jobs. And all countries of all income levels must ensure occupational safety and health for their nurses. Beyond PPE and physical safety, nurses and all healthcare workers deserve timely pay, sick leave, health insurance, and mental health support. Nurses must be properly valued and represented in health leadership roles, where they can work to guide health policy and investment. To all nurses everywhere, thank you.
In preparing for tonight's presentation, I found it really incredible to see the great work that so many pioneers of nursing have embarked on throughout the years. Next slide. During wars, in military service, in hospitals, in poverty, and in geographic isolation, and yes, even during pandemics, nurses continue to play a vital role in providing healthcare services. Next slide. Next slide. It is important to recognize this year also celebrates the lifelong commitment and dedication that Florence Nightingale had towards reducing human suffering, healthcare reform, and healthcare for all. Florence was not only the founder of modern nursing, her work forever changed nursing and revolutionized the profession. She advocated for common sense, lifestyle saving care for patients that continues to this day. Florence's lessons apply today as we are amidst the COVID-19 pandemic. The importance of proper hand washing and physical distancing are both strategies that she championed within her own practice. Her work in promoting cleanliness and sanitation and hygiene are as relevant today as they were when she started her work in the 1800s. Florence Nightingale's work spanned decades. She became a public figure of admiration. She had established the Nightingale Training School for nurses, and women aspired to be like her. Nursing was no longer frowned upon and in fact became an honorable vocation. She penned numerous publications and shared her environmental theory in her famous book, Notes on Nursing, What It Is and What It Is Not. We have all had nursing mentors, leaders, and role models in our career who have guided us, challenged us, encouraged us, and supported us. Many of you watching this evening are also those leaders who are guiding our novice nurses, which is even more challenging than it was before, and even more important now in the future, given the new challenges facing our changing world. On behalf of CANIBD Steering Committee, CSGNA, and Crohn's Colitis Canada, I'd like to thank each and every one of you for your commitment, hard work in advancing nursing, and most importantly, in IBD nursing. Next slide. Now we would like to show our respect for nurses and share a few images shared by our CANIBD group to commemorate the Year of the Nurse. Thank you, everyone. So now I'd like to move forward with our program for this evening. I'd like to welcome our moderator for tonight's program, Melanie Watson. Melanie Watson has been practicing as a pediatric nurse practitioner since 2013 at Children's Hospital, London Health Sciences Centre. She is an adjunct assistant professor at the Arthur Labatt Family School of Nursing at Western University. She graduated with her Master's of Nursing, nurse practitioner at the University of Toronto. She completed her Bachelor of Science in Nursing at the University of Toronto as well. Melanie completed her Bachelor of Science of Honors Biology at Western University. Melanie quickly honed her practice to focus on children aged 18 and under that had been diagnosed with inflammatory bowel disease, specifically Crohn's disease or ulcerative colitis. Melanie provides comprehensive care to patients and their families, predominantly through the pediatric outpatient IBD clinics. She manages the outpatient biological therapies and provides telephone triage for the IBD population. She is a proud member of the CANIBD membership as well as the CANIBD steering committee. Melanie enjoys teaching and is a lifelong learner. She has a passion for pediatrics and continues to cultivate the pediatric IBD program at Children's Hospital. She is a busy wife and mother of 3 children. She enjoys spending her time traveling. Well, that's a little tricky right now, but anyway, welcome, Melanie.
Thank you so much, Jennifer, and welcome everybody to the CANIBD plenary session of IBD nursing yesterday, today, and tomorrow. So first of all, I'd like to thank our participants tonight and all of our speakers for taking time from their evening to spend with us tonight, as I know many of us have already had long working days. So I hope you have a beverage, or maybe you've refilled it, whether that's a sparkling one or red or white one. So you can sit back and relax and listen to the wonderful sessions we have planned for you tonight. In appreciation of the Year of the Nurse and the Midwife, we will be taking a virtual trip around the world, since we can't really travel, to gain some perspective on IBD nursing, both at national and international levels. So we will have the privilege tonight of hearing from 4 of our expert panelists. Each of our speakers will educate us on their experience and evolution of IBD nursing practice. Now, based on the history of our CANIBD group, I anticipate we will have a dynamic and engaging discussion following all of the speakers. So with that said, please feel free to submit your questions or comments using the chat box throughout the presentations. And at the end, we will have plenty of time to answer all of the questions, and our experts will have an opportunity to address them for you. So we will be starting in Halifax, Nova Scotia, Canada, with Phelan. Then we're going to be heading over to Denmark, where we'll hear from Palle Bager. Then we'll head down to Australia to hear the perspective of Heidi, Jensen. And then finally back round to our friends south of the border in Chicago, USA with Michelle Rubin. So I'd like to introduce all of our speakers first, and then I will hand over the reins. So first up, we have the pleasure of hearing tonight from Phelan, and she is a nurse practitioner employed by the Nova Scotia Health Authority and works collaboratively with the Department of Gastroenterology of Dalhousie University. She's a core member of the Nova Scotia Collaborative Inflammatory Bowel Disease Program. She graduated from Dalhousie University with a Bachelor of Science in Biology before studying nursing at the Victoria General Hospital in Halifax. She then went on to do a Master's of Health Science and Nursing at Charles Sturt University in Australia, and a postgraduate certificate at Dalhousie as a specialty nurse practitioner. Now, Kelly is a little bit of a pioneer for Canadian IBD of sorts, as she was the first IBD nurse practitioner in Canada and has acted as a mentor for many nurses developing the role of IBD nurse specialist. Kelly's practice is largely clinical and focused on improving patient experience. He established the IBD patient helpline and urgent access so that patients with a disease flare can be seen and treated in a timely manner. She was part of a team that developed a transition program with the IWK, which is located in the Maritimes in Canada, so that the care of adolescents moving to adult care would be smooth and continuous. In 2014, along with her fellow NP, she received Accreditation Canada and Canada Health Info Way Leading Practice Awards for the development of an IBD electronic data management system for ongoing chronic disease management. So really excited to hear from her. We will then be hearing from Palle Bager, who is a clinical nurse specialist, senior researcher, and associate professor at Department of Hepatology and Gastroenterology at Aarhus University Hospital in Aarhus, Denmark, and the Faculty of Health at Aarhus University, Denmark. So he obtained his nursing degree in 1987, a Master of Public Health in 2008, and completed his PhD in 2014. He's been working in the field of gastroenterology for decades, and he's been involved in European IBD activities for years. He is a committee member of the Nurses European Crohn's and Colitis Organization and has been the chair from 2017 to 2018, and actually has been a member since 2014. He conducted a body of research with IBD, which this is a little bit of an understatement because when I was Googling, I found he had at least 97 publications in which he was listed as an author, and specifically an author on that second NECO consensus statement on the European nursing roles in caring for patients with Crohn's and ulcerative colitis. He does have an interest in fatigue, anemia, health-related quality of life, adherence, and service development. So welcome, Palle. Next, we will be hearing from Heidi Jensen Harris, and she is a IBD clinical nurse consultant at Mater Hospital, Brisbane in Queensland, Australia. She's been working as an IBD nurse since 2008. She started her career in New Zealand in 1996, where she worked in acute medicine before living and working in the UK and USA for 7 years in various specialties, including HIV, gynecology, and school nursing. Heidi has a postgraduate certificate in gastroenterology from Queensland University of Technology. Heidi is an active member of the IBD Nurses Australia and is currently the vice chair. She has an interest in healthcare decision-making, especially in young adults with IBD, and manages a young adult and transition service. She is passionate about advocating for patients to have the best possible care by using a holistic approach. And finally, we will hear from Michelle Rubin in the US, and she is an advanced practice nurse certified as a clinical nurse specialist in IBD and certified as a gastroenterology nurse. She has 40 years of experience in IBD at the University of Chicago Medicine, ranging from positions in nursing leadership, IBD research, IBD clinical nurse specialist. She is also the Associate Director of the IBD Center and Director of Advanced Practice Nursing at the University of Chicago Medicine. Michelle works closely with the UCM multidisciplinary IBD patient management team, with the IBD surgeons, the gastroenterologists, and all of them in managing the care of IBD patients and families. Michelle is a known leader and lecturer on IBD across the country for various organizations. She's authored and co-authored numerous articles and has participated in research focusing on IBD. She's a professional member of the CCF and was recently honored with the National Crohn's and Colitis Foundation Uniting to Care and Cure Awards in June 2020. She's the current second-time chair of the National CCF Nurse and Advanced Practice Provider Committee and a member of the Crohn's and Colitis Foundation National Scientific Advisory Committee. Michelle was a past Midwest Regional and National Giving Excellence Meaning Award for Excellence in Community Care. And she also has been nominated for the 2020 Sherman Award to be honored in the fall, which honors outstanding individuals in the fight to overcome Crohn's and ulcerative colitis. So we've got quite the lineup tonight. And with that said, no further ado, I'd like to pass the reins over to Kelly Phelan Kelly as our first speaker. Welcome.
Thank you, Melanie. Thank you very much for that introduction, and thank you, CANIBD, for asking me to speak tonight. I'm coming to you from my spare bedroom in Eastern Nova Scotia, in Eastern Canada and Nova Scotia, and I'm really excited to talk to you about how we developed the role here in Nova Scotia and in Canada of nursing for IBD patients. Emily, can you advance the slide, please? So those are my disclosures. You can go right next to the next slide, please. So today we were asked to discuss and review how I became a nursing expert, the evolution of the role that I'm in, what IBD nursing care looks like in Canada and how it's evolved, how COVID-19 has impacted that care, and give you a look at some of the practices that we've developed here in Halifax. Move forward, Emily, next slide. So in Nova Scotia, the history of NPs happened in the late 90s. In 1995, there was a minister's working group that was established to investigate the feasibility of introducing the role of nurse practitioners in the province. And it was decided very early on that nurse practitioners in Nova Scotia would work in collaborative practice with physicians as opposed to being independent practitioners. Next slide. In the 1990s, at about the same time, Capital Health, which is the largest tertiary care institution in Nova Scotia, developed the role of what they called at the time the expanded role nurse. And what they did is they used experienced nurses who were willing to complete a master's in nursing and do training in health assessment and pharmacology. That training at the time was mostly provided by medicine because there was no master's as a nurse practitioner yet at Dalhousie. And this role functioned under the delegated medical functions, and it was designated to fill the gap until legislation was available to support nurse practitioners. Next slide, please. So the ERN role was born in Nova Scotia. I always hated this name, the ERN. It made me feel like a great big nurse. But anyway, the ERN roles developed in Nova Scotia, initially in cardiology, thoracics, and then surgery, and then eventually in hepatology, nephrology, neurology, and then GI. Next slide. In 2002, the RN Act was passed by the College of Registered Nurses in Nova Scotia, giving them the authority to license nurse practitioners. In the first year, there was 15 MPs, 9 in primary health care, and 6 of us as specialty nurse practitioners. Next slide. So in January 2002, I was hired and a collaborative practice IBD clinic was established with 4 gastroenterologists initially and a nurse practitioner. It was the first such IBD collaborative practice in Canada, and the goal of the clinic was to increase access to quality healthcare, improve patient knowledge of IBD, and to encourage self-care. And it's really interesting because this came from a slide that I did many years ago. And it amazes me that the goals of our care are very similar to our goals now. So really it hasn't changed that much. Next slide, please. So here I was hired as a new NP, and I was told to, start a practice as an IBD nurse practitioner. And I thought, okay, the first place I'm going to look or I'm going to start is I'm going to find out where other people are doing the same thing. Well, I soon realized that nobody else in Canada was doing what I was going to try to do. And it was very difficult at the time, back in 2002, to find any literature on advanced practice with IBD. I did find an article by a woman from the UK by the name of Nightingale, and it kind of became, for lack of a better term, it became my Bible. I looked at it often and frequently. She was able to demonstrate a decrease in hospital visits by 38%, hospital bed days by 19%, and to improve remission rates by 6%. She was also able to improve patient satisfaction and education and avoidance of illness. I actually spoke to her by telephone a few times back in the day, and she stressed to me the importance of a patient helpline. She felt it was the key to her successes. Next slide, please. So as I moved forward, I did learn a few things along the way, and I learned that there were some key things that were necessary to make the role or the development of the role easier. One of them certainly was an extensive orientation into the care of patients with IBD. You had to know the disease, you had to understand the patients and their struggles. I thought it was very important very early on to have an NP mentor. I was very lucky at the time. There was an NP working in hepatology, and I was very fortunate. She took me under her wing and she helped me, and it really helped me evolve or develop the role. And something that we didn't think about or we didn't plan for was the need for administrative support. Back in 2002, we were using paper charts, and you know, it was who was going to pull the charts and who was going to file the charts and who was going to book the patients. Very quickly, we realized that I needed some administrative support. So within our collaborative practice, the initial plan was for the NP to take care of just the stable patients. So I was going to take care of the patients who were stable on therapy and basically do the follow-up. Well, very quickly that all changed because the need was with the patients who required quick access, the flaring patients, the sick patients. So within a year, 18 months, that's who I was caring for. And by 2006, the NP practice was full and closed to new referrals. Lucky for me, a second NP was hired in 2006, and I think many of you know my friend and partner, Barbara Curry. Next slide, please. So we now had two NPs. So what do we do? How do we change things? How do we make it better? How do we improve care? So what we felt was probably the best way to help patients was to improve urgent access. So we developed an urgent access collaborative care clinic for outpatients at Capitol Health. Next slide. So what we were hoping to do was determine the feasibility of an urgent access nurse practitioner clinic for inflammatory bowel disease and to explore the benefits of open access. What if patients could come very quickly after they needed to be seen? Next slide. So at about the same time across the country, the Canadian Association of Gastroenterology was looking at wait times. And they interviewed 200 GI specialists and the 5,500 patients, and they found that 50% of patients referred by a family doctor waited greater than 2 months to see a GI specialist, and 25% waited greater than 4 months. Once seen, 50% waited another 6 weeks for diagnostics. And wait times were long, regardless of referral center, so whether we were talking a community or a teaching hospital. 2 out of 4 patients classified as urgent. Now, these are the patients that we felt in many cases would be our IBD flaring patients who ought to have been seen within 7 days, waited 14 days, and 1 in 4 waited more than 5 weeks. Next slide, please. So we developed a new model. So the old model, we had one NP following an array of patients doing her best to see urgent patients and fit them in. And then with the new model, we had 2 NPs. Initially, with the old model, we had only 4 gastroenterologists, but we thought, okay, we have 2 NPs now. We're going to open it up to the whole division. So we had 2 NPs working with all the gastroenterologists, which, as I remember, was about 9 or 10. So any one of the patients of those gastroenterologists or of our patients who were flaring would get urgent access. The NPs would rotate weekly between the acute urgent access clinic and between the follow-up clinics. Next slide, please. 1 NP ran the follow-up, 1 did urgent access. Patient was seen in IBD urgent access clinic with complete history and physical performed by the nurse practitioner. There was always a gastroenterologist covering that clinic, and consultation took place if the NP felt it was necessary. The patient was then followed up again by the NP within 14 days of the initial assessment. Next slide, please. What we did and what we found is that we were able to see 80.4% of our patients who required urgent access within 7 days, and an additional 6% within 14. Next slide, please. So we felt that we had been very successful. We had 80.4% of NP patients were seen within 7 days of the initial consult, as compared to 43.8% of the physician patients that were seen within 7 days. Next slide. Yay, we were happy. Urgent IBD patients requiring referral within 7 days were triaged and seen in clinic approximately 50% sooner than they've been seen with the NP compared to the gastroenterologist. So we were very fortunate in that we were able to improve access. Next slide. But like everything else, success came with its challenges. Next slide, please. One NP doing urgent access for the whole division proved to be very difficult to manage. We were essentially victims of our own success. The volume of patients was high, as was the acuity. The initial plan was for the urgent access patients to be stabilized by the nurse practitioner and then sent back to the gastroenterologist for follow-up. What happened over time is those patients kept funneling back into our system through the helpline. So they would be well for 3 months, and then they would get sick again, and they would call the helpline, and they would come back. So it didn't seem that we were ever really discharging patients or sending them back to the gastroenterologist. We ended up, in a lot of instances, caring for them long-term. Next slide, please. So we were forced to change the model again. We were then following approximately 800 very high acuity patients, and we could only manage urgent access for those patients. Patients referred to the division were seen by the GI and referred to the NP if it was felt necessary. For example, if they required urgent biologic access, or if they had additional educational or psychosocial needs. We also continued to follow all the patients transitioned for pediatric care, and we kept 2 to 3 clinic appointments open every day to follow those patients who needed urgent access. Around the same time, we were in consultation with IT, we developed an independent IBD database, and we were awarded the Nova Scotia Health Authority Bronze Award, a Canada Health Influence Innovation Award, and an Accreditation Canada Award. Next slide, please. So while all this was happening in Nova Scotia, there was an evolution of the role as well across Canada. So concurrently, IBD nurses in Canada were developing practices and setting standards. In 2006, the GI IBD Nurses Group was started by 2 Canadian IBD research coordinators. And this meeting, they had an annual meeting that was piggybacked onto the Canadian Association of Gastroenterology meeting. And their meeting was focused mainly on education and networking. In 2008 to 2010, the Nurse Initiative in IBD Care and Education in Canada group was formed, and they developed modules to support nurses, modules for nurses to help them teach patients. In 2013, there was a survey of the landscape of IBD nursing done by Stratton, Curry, and Shannon, and they were looking at what types of IBD nurses were practicing across the country. And then in 2015, CANIBD was established to help meet the need of the Inflammatory Bowel Disease Nursing Network, where best practices in IBD care could be shared. I looked at the list, and I think currently there's approximately 150 members of CANIBD. Next slide, please. So we continued to grow in Nova Scotia. We have recruited an IBDologist in the name of Dr. Jennifer Jones, and our team grew. We continued to partner with our health psychologist. Over the next several years, we achieved funding for a designated nutritionist, although it was only 0.2, and funding was secured for a nurse navigator position. There was the development of the Nova Scotia Collaborative IBD website, and an EMR was secured, and we developed IBD-specific templates. Next slide, please. So the model changed a little bit again. The new model, with the help of the nurse navigator, was that she was the center of the model, and she helped facilitate people come in and out of the care that they required. The nurse navigator, we saw her as our quarterback. Next slide, please. So now we had 2 full-time nurse practitioners in Halifax and 2 part-time nurse navigators. We consider ourselves very lucky. The nurse practitioners manage the care of the patients considered at risk. They see the patients who are newly referred to the program. They do urgent access for a flare care. They do new biologic starts, and they do all the pediatric transition patients. The nurse navigators manage the patient helpline. They provide care coordination, patient education. Jessica, one of our nurse navigators, has developed a vaccination clinic, which is just awesome. So we can send our patients to get their biologic vaccinations done. And they've also developed what's called a biologic care pathway. Next slide, please. So as part of the instituting the role of the nurse navigator, we also did a little bit of a study, and this was presented at CAG to look at the effectiveness of the IBD nurse navigator. And what they found, next slide, was that there was a high volume of healthcare appointments required by these patients, and treating and managing IBD care was complex and overwhelming for patients and their families and their healthcare providers. The nurse navigator was a vital point of contact for these patients, with patients relying heavily on the nurse navigator for care coordination in their IBD. The nurse navigator role has the potential to reduce emergency department visits and improve delivery of specialist and social services, as well as support overall quality of health, quality of life. This has been a very vital role within our division. But like everything else, if it doesn't challenge us, it won't change you. Next slide, please. Then this happened. So we were moving along nicely, we were growing, and we were evolving. And like everybody else I'm sure I'm speaking to tonight, we all had to make changes quickly when COVID happened. Next slide, please. So one day on March 15th, I was in clinic seeing patients, and the next day on March 16th, I was at home doing virtual care. That's how quickly this happened. We went virtual almost instantaneously. I don't think I missed a single day of clinic. We started using telephone calls, and then we were using video chat. So we're still doing almost all of our care virtually. We currently go into clinic 1 day or 1 to 2 days per week. With COVID, there was reduced access to colonoscopy. That has now improved in Nova Scotia, but initially it was quite an issue for us. The other thing that happened as a result of COVID was that we had a decrease in the amount of steroids that we were using. So, sorry about this, my computer just shut down, but just give me a second. Thank you for your patience. So there was a decrease in the amount of steroids that we were using because we knew that steroids were a risk factor if our patients were to contract COVID. Because of this decrease in steroid use, we also found at the same time we were getting a quicker initiation of biologic therapy. We were getting patients on biologics quicker because we wanted to avoid using steroids. The other thing that was a little different is we got a little bit more careful with our combination therapy. If we had patients who were stable on combination therapy, who had a normal fecal calprotectin and who were feeling well, then in many instances we would stop the immunosuppression and just treat them with the biologic. We came to realize as the pandemic progressed that the actual largest risk factor for patients with IBD contracting COVID was having active disease. This certainly helped us in our abilities to keep and get patients on therapy. Once, a lot of our patients in the beginning were reluctant to stay on immunosuppressives or on biologics, but once they realized the risks for them was actually higher if they had active disease, it made the conversations a little bit easier. Next slide, please. We had a particular change in our patient helpline pre-COVID. In 6 months prior, in 2019, we had about close to 1,300 calls coming to the helpline. In 2020, it was close to 1,800. So we had approximately a 30% increase in the number of calls that came into the patient helpline once COVID happened. Next slide, please. We also had an impact on the new referral times of patients to be seen, and believe it or not, we actually got better at it. We were able to see patients quicker once COVID happened. Instead of taking 21 or 22 days to see a patient once they were referred from the family doctor, we were seeing them in about 7 or 8 days. Next slide, please. So COVID had a significant impact on the way we practiced, and we're still starting to look at some of the changes and how they've affected our practice. But certainly, for the most part, we've been very fortunate here in Nova Scotia. Our numbers have been low, the Atlantic Bowel has been safe, and we have been able to see and care for our patients for the most part virtually. So the last thing they asked me to do as part of this talk is to share some of our practices and some things that we've developed here. So I'm going to, next slide, please. I'm going to talk a little bit about our biologic care pathway. So this looks like a very difficult, complicated diagram, and it's not actually that complicated. Next slide, please. The pathway was designed to standardize the pre-biologic workup and improve care coordination between clinicians and biologic coordinators. It was designed to standardize early TDM and fecal calprotectin and provide nurse assessment of symptoms to facilitate early dose escalation if necessary. It was also hoped that it could reduce the number of in-person patient follow-up visits that we did. So essentially what happens is once a patient, it's decided a patient needs to go on to a biologic, they are referred to the nurse navigator to be put onto the biologic care pathway. The physician or nurse practitioner who refers them will organize or order the pre-biologic workup, like the chest X-ray and the TB tests and the blood work, and the biologic, nurse navigator will make sure it all gets done. She will make sure it's all completed before the okay is given to the drug coordinators to start therapy. Once the therapy is started, patients receive fecal calprotectin and therapeutic drug monitoring based on a schedule in relation to the particular drug that they're on. At 16 weeks, every patient receives a call from the nurse navigator to have a symptomatic checkup done. They do have the broadshots and they see how the patients are doing, and then they report back to the clinician. Next slide, please. So we looked at the effectiveness of a standardized biologic care pathways, and this as well was presented at CAG. Next slide, please. And what we found was that there initially was significant variation in the use of biologic therapies with different individuals and health systems, and that this discrepancy can lead to loss of response or drug intolerance, potentially affecting medications. And implementation of a standard biologic care pathway can better inform clinicians on best practice when treating IBD patients with biologic therapy. Preliminary findings with the pathway suggest that patients managed with the pathway, their treatment was guided more often by the results of their TDM and objective biomarkers than those not managed on the pathway. Although clinical remission was observed to be similar between both cohorts, attainment of endoscopic remission was more likely if patients were on the biologic care pathway. Next slide, please. So those are a few, that's an explanation of one of the tools that we've kind of evolved in Halifax. I've been doing this job, or I've been in this role for almost 20 years now. I've enjoyed every year of it, and I've learned a few things along the way. What I believe very firmly is that every patient in Canada deserves access to quality, specialized IBD nursing care. This can facilitate disease knowledge and improve timely access to care, as well as improve patient outcomes. As IBD nurses, we need to promote further role development and support those nurses who are working to establish practices. Next slide, please. I want to thank you all for listening to me. I'm hoping it wasn't too dry because it was that history of IBD in our practice, but thank you all for listening.
Thank you so much, Kelly. That was just a fantastic presentation, and it was so interesting and stimulating to hear about how you and your program have evolved and had to pivot even your focus with you know, the changing landscape of IBD. So thank you so much for that talk. That was great. You know, next, I think now I'm very excited to introduce Palle, who will be our next speaker. And I'd like to give the floor, the virtual floor, to him. Thank you.
Thank you so much. I'm not really sure if I can shift the slides, but otherwise I'll ask for the next slide. Please. Next slide. Yes. I have no conflict of interest. And next slide, please. Well, this is how it looks in Denmark right now. It's 1 o'clock in the night, so if I look a bit tired, you must bear with me. Next slide, please. And I'm, of course, proud to be invited to this event and represent the only representative of the old world. And this is where I come from Denmark, a tiny country with a tiny population. Next slide, please. This is my hospital, or where I work. It's Aarhus University Hospital. It's actually the biggest hospital in Northern Europe. We just gathered all hospitals in the area a couple of years ago, and now we have all specialties, including psychiatry, in this hospital. So we have like 1,000 beds and 1 million outpatient visits a year and 10,000 employed at the hospital. Next slide, please. So this is what I intend to talk about in my 20 minutes. And of course, I have most of my experience from Denmark and also some experience from Europe, from ECHO, as you were told in the presentation. So I'll talk about Denmark for 10 minutes, more or less, and then about the challenges in Europe and what we've been doing in ECHO and nurses ECHO called NECHO. So next slide, please. Well, in Denmark, I don't know so much about the Canadian healthcare system, but in Denmark, most of the healthcare system is public. And I guess almost every IBD patient is seen in public hospitals. And they're not seen by a general practitioner. It's mainly in hospitals. When I was educated as a nurse, I was employed at a hospital and had my education there. But around 20 years ago, the nurse education became a bachelor education for 3.5 years. And then you can add a master degree, which is additionally 1 or 2 years. And then we just started the education of advanced practice nursing. So we don't have what I guess you have in Canada, a nurse practitioner. So we have no right to prescribe any drugs so far, but we're working on it. Next slide, please. And as the slides I saw in the beginning, I can see that it's more or less similar how nursing was in the past in Denmark. And I would say particularly IBD nursing was more or less invisible, because I guess IBD patients were mainly in surgical departments. And then I think IBD nursing in Denmark became more and more clear with the introduction of biological. And especially, I think, when we have to teach patients to take subcutaneous therapy, I think the value of IBD nursing became more and more clear, both for the patients, for the doctors, but also for the industry. So I think from that point, and that's probably 15 years ago, I think IBD nursing in Denmark developed rapidly. Next slide, please. Well, no, that's better. So what has the challenges been, and what is the challenges? Well, it's still a challenge that the nature of taking care of people is not always acknowledged as a skill. So I think in my what's that, 35 years of nursing, I think it's becoming more and more a profession, but still it's still regarded as a natural skill, and that's also we can also see that there has been a lack of prestige, and also our salary probably is the same in Canada. Is still far behind other groups of health professionals. And then we've been struggling all the time with the lack of nurses, and we still are struggling that. And then we have some union issues that, well, I don't think our union is so particularly strong, and it's also a problem and has been for many, many years. But let's continue to the current practice. Next slide, please. So IBD nursing today in Denmark, I think it's quite similar to what we just heard, that we run advice lines, and we've been doing that for many years. When we started, in my department, started advice lines, we asked the patients prior to both the advice lines, and also we have an annual telephone consultation by a nurse. So we wanted to convert appointments with annual telephone calls. So we asked the patients, how would you like that? And everyone, mostly everyone was excited, except from older male patients with IBD in remission. They would like to see the doctor still, and that's, well, maybe it's not so surprising. So we have had advice lines for many years, and we've been doing education of patients. I think we've been running IBD schools for almost 15 years. And we just heard about the COVID-19 situation in Canada. And I think we realized this year that we need to make our patient education virtual as well. So I think we'll record our education sessions so the patient don't have to show up. Then we introduced nurse consultations, some kind of e-health activities. And then I think we've been doing more and more research, both in Denmark, but also internationally, on mainly health-related quality of life, adherence to treatment, fatigue, as I'm especially interested in. And you should keep an eye on an article in APNT later this year. We've done an interesting study on fatigue and the treatment of IBD fatigue. So keep your eyes open. On the right-hand side, you can see in my department, we did a little book on IBD nursing, and it's very tiny book. It's fits for what's it called, the pocket, and it's not about treatment. It's about what you have to do, what you have to be aware of being a nurse and taking care of IBD patients. Next slide, please. So what will the future bring? Well, I think we'll gain more and more responsibility, and I think we are more and more confident as nurses. But we also have a challenge that there's more and more rapid staff turnover. I think compared to when I was educated, I think younger nurses tend not to stay for many, many years in the same specialty. So I think we have a challenge that when we educate nurses to become IBD nurses, we cannot be sure that they actually remain in the IBD ward. And I think has nothing to do with IBD. That's a general problem. Then we'll probably have some more e-health, and I think we have to be aware as nurses how we implement e-health, because we can easily be bypassed as nurses because if e-health is the patients having a consultation with the physicians, we can bypass some care issues and some nursing issues. So I think we need to be aware that nursing is part of the e-health as well. But also we've focused more and more on patient-centered care, and I think we focus on patient participation. So I think there's a great future for IBD nursing. Next, please. So what can we be proud of here in Denmark and regarding IBD nursing? Well, as you can see on the landscape there, Denmark is rather flat, and it's pretty it's tiny and flat, and that's also the way our healthcare system is. I think we have a very flat structure. It's very easy nowadays to communicate with our colleagues, with our physicians, and I think there's quite a lot of respect about nursing in Denmark. And also we have a high credibility. There was I think it was last week, we turned out to be the second highest credibility in all professions after midwives. And I think we could be proud of that. But let's turn into Europe. Next slide, please. Because I have a feeling that some of you know about ECHO and NECO, and at least one who's been in the NECO committee for some years. Yusha, which I've seen on several pictures this evening. But ECHO is the European Organization of Crohn's and Colitis, and it contains of many professions, including nurses. And here on the bottom, you can see we started out the nursing committee in 2008, and we have been increasing over the years. Next slide, please. But I know we have several languages in Canada, but this is the language map of Europe. And being a European organization has some challenges. And I would say languages is the main challenge because, of course, we have a common language in English, but it's not every nurse in Europe who speaks English and understands English. So we have a language problem, but also we have problems with different cultures, different way the healthcare system is organized, etc. But on the other hand, I think there's some benefits of being such a pathwork of countries, because we can definitely learn from each other. And I think one of the advantages of ECHO and NECO is that some countries can learn from, for instance, our consensus statements, that this is the way we would recommend nursing to be in Europe. Next slide, please. This is pictures of hospital wards in, I won't mention which country, but the one below is from my hospital, and there's some differences in the way we meet patients in Europe. So that's another challenge, that it's the conditions for IBD nursing is very, very different. But on the other hand, I think we need to set a high standard for nursing, and I hope we did that with the consensus statements. Next slide, please. This slide shows the organization of ECHO, and you might not be able to see all the boxes, but what's important is that nurses is part of the whole organization, which means that we're part of the whole family. We're not just an appendix to the physicians in ECHO. So there's many professions, there's many specialties, there's surgeons, there's pediatric group, there's young ECHO members, etc. So we are part of the whole organization. We are also been invited to take part in different guidelines. I've just been part of the Crohn's disease guidelines based on grade system, where of course there was a lot of physicians, a lot of surgeons, there was nurses and a patient participation as well. So we're invited in, and that's absolutely an advantage for nursing. Next slide, please. So what do we do in ECHO? Some of you might have been to the annual network meetings. And I'm pretty sure Yusha has spread the word because she's been there for many years, and she's been part of the ECHO committee for 3 years. And it was a pleasure, Yusha. Yusha was actually running the ECHO school for 3 years, and the ECHO school is it's for nurses who are not so experienced in IBD nursing, and you can send 1 or 2 nurses from each country, and it takes place on an annual basis at the ECHO Congress. And we have had the school for, I think, 10 years or some 10, 11 years. Then we have created a research forum every 2nd year, where researchers, experienced researchers as myself, are together with the young IBD nurses who is willing to or wanted to get into research, and we create research across Europe, and we also hand out research grants every year to encourage people to do research across Europe. Then we did nurse education, and as I mentioned before, language is a great problem in Europe. So while the ECHO school is in English, we realized that if we really wanted to educate nurses who are not really into IBD nursing yet, but for instance doing endoscopy, maybe giving infusions, we need to tailor our education to a specific language. So me and a colleague from the UK, Karen Kemp, which some of you might know, we created an education program along with the EduCom in ECHO, and we picked 1 country, and we ran the education last year in Italy. And I think it was a great success. Of course, we learned something that we could change and do better. And now I'm out of ECHO, but I believe that they have picked or will pick another country for the next course. It was a half-year course with 2 face-to-face meetings and some e-learning in between. And we can do that because we have a large body of e-learning materials in ECHO. But I must admit, I don't know if they can run this education due to the pandemic situation. But it was a good experience, and I think we actually did raise the level of IBD nursing in Italy during this. Then we have national representatives, and that's also a good way to network. Then we did the consensus statements, and I've been part of it, both the first and the second ones. And I could see the development of research papers from nurses in the 4 or 5 years that was in between the 2 statements. So I think we're on the right track, and there's more and more IBD nursing evidence out there, and just keep on adding, because we need that. So instead of doing statements, we could maybe create some guidelines one day if we have evidence enough. Then ECHO also provides travel grants where it's possible for nurses to travel to another country to see how IBD nursing is performed there. And as I mentioned, we have a lot of e-learning material. And next slide, please. And here is a selection of activities. And you can see the first picture on your left-hand side is from the NECO school. And on the right-hand side is the NECO network meeting. And then there's some talking heads material. And if you're a member of ECHO, you have access to all this e-learning material. We have the consensus statements where you can see also USHIP being part of. We did a systematic reviews on advice lines for patients with IBD. We also have some e-learning about non-inflammatory symptoms in IBD. And together with Yusha as well, we did a toolkit if you wanted to establish an advice line, what questions you need to ask yourself and your organization before you start. So I can only encourage you to become a member, and it's not so expensive if you're a nurse. And then you have access to all this wonderful material, and more will be added in the time to come. And I could imagine that the congresses in the future would be a combination of physical congresses and virtual congresses. So please have a look at the homepage or ask Yusha how ECHO is running, and I'm pretty sure she'll agree with me. Next slide, please. So what is there to be proud of in ECHO? Well, I think what is the greatest thing is that we as nurses have an almost equal representation in ECHO. And we also, as I told you, we're invited in guidelines and things. So we're equal partners. And then I think we have we're forced to have a broad approach to IBD nurses because there are so many different ways to practice nursing in Europe. So we need to think of IBD nursing as how it could be performed in many settings, and it can be very inspiring. Furthermore, I think there's a high awareness from sponsors, which means that it's well, I won't say it's easier, but it's not such a challenge to get sponsorship for different things, including research. And I think that's because we're so strong in NECO and in ECHO. And I just to bring all this ECHO stuff into perspective, as the way I was presented, I'm working in a department of hepatology and gastroenterology. And I've actually been involved in the European Liver Organization and been part of the Nurses Liver Organization in Europe. And this organization is more or less where ECHO was maybe 10 years ago. And it's my ambition to inspire this liver organization with what we have achieved in ECHO, because liver nursing is still more or less invisible in Europe, and also when it comes to nursing research. So I think ECHO is worth highlighting the way ECHO runs. Maybe it's the last slide. Can I have the next one, please? It was. So I don't know if I spent too much time, but that was about it.
That was wonderful. Thank you so much, Palle. It's so interesting to hear about NECO, and what a great way to introduce those resources to all of our IBD nurses that don't know about it, and just to hear about some of the similarities and differences that you experience in Denmark compared to what we do here in Canada and the rest of the world. So thank you so much for a great talk. So with that, I was hoping that we can have just a 5-minute kind of stretch break, give everyone a chance to refill their beverages, maybe a bio break, and then we will meet back in 5 minutes, but please do not log off. So right now I've got the time locally here is 7:25. So in 5 minutes, it'll be 7:30, and we'll meet back to hear our next speaker.
Oh boy. Uh-huh. I think so. Can you stay close?
Yeah, I'm just there. Have you started or not?
Hey.
Have you started or not?
I'm starting in 2 minutes.
Okay, welcome back, everybody. It is now 7:30 our time here, so we were hoping to continue with the rest of the program here. And I have the pleasure of introducing Heidi Jensen Harris to give us the perspective of IBD nursing from down under in Australia. And with that, the virtual floor is yours, Heidi.
Thank you so very much. I just want to thank the organisers specifically for the invitation to speak at this meeting. I see it as a real opportunity to network and learn from what has happened all over the world. Thank you so much, Palle, for telling us about what's happened from a Danish perspective. And I very much enjoyed listening to the perspective there in Halifax as well. Thank you so much. First of all, I'm going to introduce myself. I'm going to see if I can use this mouse here. Okay. I think I might actually have to, doesn't seem to be doing it for me there. Emily, I'm wondering if you can advance the slide for me.
I will do that for you. We had it there for a second, but it did.
It did. We had it. It worked. Anyway.
Oh, no problem.
Thank you. The first slide here is a photo from the family farm where I grew up in New Zealand. New Zealand is a very rural country. Some of you may have visited New Zealand. This is the central North Island, where on our farm you can see the volcanic plateau in the center of the North Island. That's an active volcano there. So this is where I grew up. And then I went away. We'll go to the next slide there. I started off in New Zealand, and I took myself to London, this was after a couple of years of nursing, and I worked in London at St Thomas's Hospital. After the lowdown on Florence Nightingale, I worked in the hospitals where Florence Nightingale nursed. In fact, I nursed in a ward which was a Nightingale ward that was 30 beds all in a row, and it was full of patients in the 90s when HIV and AIDS was still a real problem, completely different landscape now in HIV. So I lived in London for around 7 years, but in the middle of that time, I went and worked in West Virginia in the United States. And when I was in West Virginia, I worked at a school for at-risk youth where I was the school nurse, and I was also the discipline coordinator at that school. The kids there called me Rent-A-Cop, and they would often ask me if you could drive to New Zealand from the United States. And I said that would be difficult. So from there, I went back to the UK again, where I really, during this period of my nursing career, I was really developing an interest in young adults, in how they make decisions and what really helps young adults to flourish. It was also during this time, I was also interested romantically in a young man who was Australian. My parents thought it was very interesting that I took myself all the way to the other side of the world to find an Australian. And I found myself in Brisbane, Australia. So next slide, please. And you know what I call people who work in IBD? I call them rock stars. I absolutely call them rock stars. And I think the talks today show that we're certainly in rock star royalty areas with these talks today, with all of the different speakers that we have. But it's such a privilege to work with people who are inspirational, who they're really there for the long haul. And I think that's what IBD is. It's the long haul, because this is people's lives and we really can have a big impact. So here's me. I'm going to call myself an IBD rock star. And this is with some of the rock stars who have influenced me. So let's go to the next slide. I thought I'd start off with some of the Australian data. We have around 800 new cases of Crohn's disease and 900 new cases of colitis every year. Over 85,000 Australians are diagnosed with IBD. And so that means other more commonly known diseases like epilepsy and multiple sclerosis and RA and schizophrenia, it's more common than that. And but it's just sort of, it stays undercover, and it certainly does stay undercover in Australia, so we're working on that. Next slide, please. So I wanted to show you a little bit about the Australian landscape. Can you guys see my mouse? Can anyone see my mouse? Anyway, this is Queensland. So here is Queensland, where I'm from, and this is actually a really big state. Australia's a really big island. And here we are in Brisbane, the red dot with 2.3 million people. And then the other red dots are where our population sit. And then there's these other smaller dots all around. And that's where larger groups of people live, but it's not significant numbers. So you really will only find a major IBD centre in anywhere where these red dots are situated. And sometimes even here, like down here in Tasmania, they're not very big centres. Next slide, please. This is to give you some perspective with how large Australia is. So here's Australia put over the top of the map of the United States of America. And it just gives you a bit of a feeling of like the kind of distances that our patients are having to travel. Now, our whole entire population is about the same population as the population of Texas. Now, next slide, please. So yes, I know I'm not presenting to American nurses, I'm presenting to Canadian nurses. And that's a really important difference. So we'll go to the next slide. Here is Australia sitting over the map of Canada. You guys are a little bit different politically to the United States. You're also a little bit different as far as the problems that you've had to face with COVID-19. But I think the Australian health system and the Canadian health system have a lot of similarities. Our quality of life is very similar, and the sort of the finances that we have available for a lot of things are very similar as well. So I was very interested to hear the similarities on how IBD nursing has developed in Canada. I think we have just started a little bit later than you guys, I think. So move on to the next slide, please. So here we are in Brisbane, Australia. This is, you know, some would say that you choose the most beautiful photo of your city and pop it up so that everybody wants to come visit. And it's true, yeah, come visit me. But this is actually what it looks like. And this is about a 5-minute walk from the hospital where I work in Brisbane. This is the South Bank of Brisbane. Next slide, please. So now I'm going to introduce you to two other rock stars, Professor Florin and Professor Radford Smith. And these guys were the foundational members of treating IBD, both in Australia and also in Queensland. Professor Florin was the first person to give infliximab in Australia. And Professor Radford Smith, he's the opposition across the river. Really, we're all in one big team. And I think globally, actually, we're all in one big team treating IBD, because my motto is we rise by lifting people up. And I think, you know, coming together in meetings like this is really what we're doing. We're all just being rock stars. Let's go to the next slide. So this is the hospital where I work. The building on the left, that's the Mater Hospital Brisbane. The central building there is our young adult centre. And down on the right, that is the Queensland Children's Hospital. Now, the central building used to be the Children's Hospital, and when we amalgamated children's healthcare within Queensland and within the entire state, actually, so all the major paediatric surgeries and things all happened within that building for the entire state. We left the central building empty, which was a children's hospital. Now, during that time of nothing, there was a bit of a suction. What are we going to do? What are we going to draw into this space? And what we realised within Australian and Queensland healthcare was that there was a big deficit in the care of the young adult on many, many levels. So that building is dedicated to the treatment of sort of 15, 16 to 29-year-olds. Next slide, please. So we're very proud of our service, and we're probably considered one of the centres of excellence within Australia as far as IBD nursing goes. And nursing goes throughout the entire spectrum of care for IBD nursing within our service. So we attend the ward rounds, we monitor the helpline, we sit in on the MDT meetings. We look at the referrals that come into our centre and help triage those. We usually do an initial consult once a referral comes into our service to see if we need to escalate that even further. and we attend the emergency department. IBD nurses are everywhere, and I'm sure as other IBD rock stars, you guys can very much recognize these kinds of behaviours. Next slide, please. So this is our team. I found it really interesting to listen to Kelly and how many nurses they have. Indeed, you are incredibly lucky within your service to have such a broad range of experience and qualified people. This is what we have here. This is a slide I've borrowed from the Director of Gastroenterology within my unit, where she outlines the human resources that we have. Interestingly, she's put the IBD clinical nurse consultant under allied health, and there's no way that we're any form of allied, but there we are. We also have a 0.9 CN that works along with myself. So one of the questions I'm going to ask the other leaders who are giving talks and also those who are listening is how many nurses, IBD nurses you have to meet the needs of certain numbers of patients. So if you can just go to the next slide, please. So here we are sitting in our inflammatory bowel disease multidisciplinary team meeting. This was, of course, a photo taken well before COVID. So these meetings all now happen virtually. We have those on a Teams platform where we can sit there and we can look at patients' radiology, histology, and patient histories and things. And those meetings happen every single week, and all of those people attend. Next slide, please. So we're very, very much focused on the overlapping of all of the services and an interdisciplinary team meeting. Next, please. So where do nurses fit into all of this? Well, we do lots of education and outreach. We attend and we strategize with the GPs in our community. We work with the Crohn's and colitis, and we put on patient forums. We attend local, state, national and international conferences. Had a lovely time in Copenhagen a couple of years ago, Palle. And we are also involved in the teaching of the medical students, residents and registrars. I say train them up. You've got to get them young so that they know what they're doing. We also have leadership positions. My colleague, Professor Jacob Began, is the head of IBD Association of Australia, and I'm the vice chair of the IBD nurses. We have PhD students. And at our hospital, we have run the IBD Foundation course, which is for new nurses, which is very similar to the nursing school held at ECHO. And these courses are run by nurses for nurses, and also a very important place to network. We also have also run the Advanced IBD Nursing School. Unfortunately, some of these courses, I'm referring back to, I think, what Kelly said, that sometimes these courses are overarched with the use of our medical colleagues to teach us more in-depth knowledge. Next slide, please. So things that we're proud of and the innovation in IBD, like Kelly, I worked with the IBD team to create a software system where we could monitor and strategize and really just manage the care of our biologic patients. We lead the biologic safety checks. We're very lucky to be able to do Saturday infusions as well as infusions Monday to Friday. And we're also collaborating with our British colleagues to run fast infusions. They've done big projects where they're giving their infusions over 30 minutes rather than an hour. I'm not sure if you guys are doing that within the UK, within Canada. We've also done big studies on switching for cost saving measures, and then we're able to reinvest those finances into our service. We've also had all kinds of mindfulness trials and psychological trials. And we also can direct the patients towards intestinal ultrasound and point of care assessment. The other thing that I'm very proud of is that I do lead and and push the fertility and maternity service here at our hospital, which is where we have all of our patients who are going to deliver within our hospital or within external hospitals, that they are presented at the maternal fetal medicine MDT, and we provide the patients with a nurse-led pregnancy pathway plan, which they keep with them. And that also has blood forms and things so that we can do cord blood at the time of delivery, so we can look at drug levels and things like that. Next slide, please. So this is just a picture of one of the patient forums that we have run at MARTA, and we had more than 120 people attend this forum, and we had some of our young patients who are musicians who played beforehand. We have young adults who are setting certificates in food preparation as part of their launching into adult life, who provided the food for this forum. And if you ever get the chance to look up Luke Escombe, he's an Australian comedian and musician, look up online, Google Chronic Symphonic. He's a very, very funny guy. Next slide, please. So one of the ways that we are able to give emotional support to our patients is we provide, we have a young adult support unit, which is run by psychiatrists, psychologists, nurses, and it's sort of a hub and spoke approach where I'm the center of that hub, and we assess our patients at every single consult that they have, and if they meet criteria, then the patients can either go into clinical trial or to usual care of seeing a psychologist if they need that. And as I was speaking about before, the fertility and maternity services. Next slide, please. So we also have a massive clinical trials unit at our hospital, and the clinical trials team are also a part of our regular MDT meeting, so that we can see if patients meet criteria to go into one of these clinical trials if they've run out of standard options. Next slide, please. And that's all a part of the MARTA Research Institute. And as I said, it gives our patients options. Next slide, please. So how did we get here? How did our service evolve, and how did IBD nursing evolve here in Australia, and especially with my own experience here in Brisbane? Let's go to the next slide. Well, in around 2014, I think, entered Professor Jacob Begun. So Prof Florin started our service, and Prof Jacob Begun really took us to the next level. He had his fingers in every single pie, both internationally and nationally, and he was very much a big supporter of IBD nursing. Next slide, please. And it was around this time that our service, the Children's Hospital was built next door. We had space for something different in the old Children's Hospital. And this was also when we did a massive national audit on Crohn's and colitis. I was a part of this, and I can remember getting trolleys and trolleys of charts, paper charts that we had to go through to see about how our patients had either succeeded or they had had timely treatment at the time of care. And there were many, many different criteria that need to be met for us to be assessed. So we went through all of those papers, and as a result, our hospital decided that we had some significant gaps in care, and Australia had significant gaps in care. And although we already had a dedicated IBD nurse, which was me, and we had a helpline, prior to this, I had started my position in 2008 at 1.5 days a week, which a lot of you will know that just sounds like a nervous breakdown. But after the implementation of these standards, I'm paid at a higher level. I'm now full-time, and I also have a colleague who works beside me at a lower level, but 0.9, which is 4 days one week, 5 days the next. And so as you can see, as a result of the research study, at that time we had between 450 and 800 patients. Now we have close to 2,000 patients, but we had a 20% decrease in the rate of Crohn's disease admissions and 15% for ulcerative colitis. This also was reflected in length of stay from 8 days to 5.5 days. And this is the kind of information that those people who hold the purse strings, they're the ones who like to see that kind of information. Next slide, please. So the IBD standards, look, they were a really long time coming, and we had those people who had worked in IBD. I suspect they're people very similar to you, Kelly, who had worked in IBD forever and who were just absolutely dedicated to the cause. They worked along with the Crohn's and Colitis Association of Australia. They were on committees, they were on boards, they were on the scientific committee. And finally, these standards were able to be presented to Canberra by the IBD advocates, as well as my own mentor. And I just want to recognise all the mentors out there who really have given of themselves over the years. And I want to introduce you to her. Next slide, please. This is Stephanie Buckton, and Stephanie would have been giving this, this talk today, except that 2020 was her year of sabbatical. What an excellent year to be chosen for sabbatical. Stephanie was going to be skiing in Europe. She was going to be traveling through Africa. But I asked her to send me a photo, her favourite photo of herself, and this photo was taken 2 weeks ago in the Northern Territory of Australia, where she's been wrestling crocodiles and running away from goannas. But Stephanie has been an absolute rock star royalty person here in Australia, and I'm hoping you all get to meet her at some point. Next slide, please. So back to the IBD standards, the audit highlighted that only 1% of IBD services met the criteria. And the criteria, I'm wondering if you guys can check these things off on your own service, where we needed a gastroenterologist, it's a really good start, an IBD nurse, a colorectal surgeon, mental health clinician, stomal therapy, radiologist, and histopathologist. Now, it doesn't seem like rocket science that you could get all these people in the same room, but it seems like in most of our centres that was the case. Next slide, please. The standards also highlighted that only 24% of IBD services had an IBD nurse. Now, I really want to be able to network with you guys there in Canada and find out more about your IBD nurses and how it is that you partner with your colleagues. But here in Australia, if you don't have an IBD nurse, you're having a nervous breakdown. Next slide, please. And so I'd just like to also highlight some of the other colleagues that I have. I don't know about IBD nurses in Canada, but IBD nurses in Australia, we're tight. We love each other, we've known each other a really long time, and we've got staying power. And I think I want to go back to what Palle said, is that younger IBD nurses aren't necessarily staying, but we just need to continue being inspirational. I guess in some ways we feel like it needs to get a little bit easier as well, but anything that's worthwhile is actually not that easy. Next slide, please. So how did we get here? Well, it's a combination of things. You know, I think Biologic's coming onto the market in Australia in 2007, and what goes along with that? We here in Australia have we have an interesting dynamic where 30% of our healthcare is privatised, and so people will have health insurance, probably very similar to what they do in the United States. But then we have the bulk of healthcare is provided is public. And the way that we have to get these medicines, we have to jump through many, many hoops to get the drugs. We have to send off to a centralised location. Previously, I was having to put applications into envelopes, post them to Tasmania in Australia, and wait for up to a month to get those applications back. Now we're actually able to upload those, but with increased biologics and increased paperwork and having to educate patients, it really was the push to improve IBD nursing here in Australia. Next slide, please. So this will give you a little bit of an example of the biologic landscape here in Australia. I don't know how it's happened in Canada, but it feels like it's just taking way too long. Tofacitinib has not even come onto the market yet, and the pharma really have to lobby at every single step to try and get drugs approved and onto our system. But with each and every one of those indications, it's a different set of paperwork. And I promise you, it takes a long time. Okay, next slide, please. So the IBD nurse group was a very, very small group of nurses who got together. It was informalized, it was word of mouth. Next slide, please. And we wouldn't meet together very often. We had our very first pharma standalone meeting. It was funded by AbbVie, and it was called Ignite, and that was in 2016. Next slide, please. And this is just a photo from that. Next slide, please. And this is when our nurses came under the umbrella of IBD Nurses Australia, and it was an existing and respected nursing body with experience and infrastructure, and this just really seemed to make sense. Next slide, please. We have around 120 members in New Zealand and Australia. We felt like critical mass was really important, so we invited our New Zealand colleagues to come along and join us, and I was very happy about that. Next slide, please. These are our aims and purposes, and for all intents and purposes, I feel like these are very similar to what I heard at the very beginning of this talk. Next slide, please. And these are our objectives. Again, very similar to what you have there in Canada. Next slide, please. So we have our foundation courses, our advanced nursing programs, and we strategize to formalise ongoing nursing education. And we're definitely learning from our European colleagues. Next slide, please. This is our advancing nurse group. Next slide. And again, very similar to what you guys have got going on in Canada as far as what you're responsible for. Next slide, please. As far as innovation goes, highly interested in IBD transition. That's something that I'm working on at the moment. I have no budget at all to develop almost anything. And so it's about being innovative. And one of the things that I've had to do to orientate and transition young adults was work with students from the Griffith Film School to organise orientation clips for patients to be able to watch online so they could be orientated and transitioned into our service. Also, the pregnancy pathway plans so that pregnant mothers have got information with them at all times to share with other practitioners about how they're going to proceed with their medications and their pregnancy pathway. Next slide, please. Next slide, please. I'm just going to flick through these next few slides. It's just really highlighting the fact that we are working with young adolescents who are in this, they're very vulnerable, but they're cognitively flexible. And I think we can really have long-term impact on how we deal with these young adults. And nurses are the first point of contact and have intimate knowledge of these patients. Next slide, please. Next slide, please. As far as COVID goes, we have been incredibly lucky. You'll see our death level. We've lost 6 patients in total here in Queensland. Next slide. We've extended our telehealth program. We went to almost completely telehealth unless a patient was in a state of flare, and then we would bring those patients in and treat them. We really struggled bringing our patients in when they really needed to because they were all incredibly fearful. Next page, please. Because as I said, the absolute risk here in Queensland was incredibly low. We did completely change the way we ran everything, but the risk was incredibly low. Next slide. The biggest challenges that we have is that our patients are so far stretched from us. Our patients are, I have had patients who I've had to ask them to put their bloods in an agricultural helicopter and drop them at a pathology lab because they are all flooded in. Australia is a place of extreme weather. I know in Canada you have 2 seasons, road work. You have summer and winter and road work. Well, we have floods, we have fires. This year we felt like our country was on fire, and now with COVID. So we just have vast distances. Next slide, please. I have a plan, and the plan is that IBD Rockstars Unite. Next slide. I'm just making this up, but I think we should all meet at Whistler in 2021 and put our heads together and solve all the IBD problems of the world. Next slide. Thank you very much. You're welcome to come see me anytime. Thank you, everybody.
Thank you so much. That's a wonderful talk. It's so nice to listen to your presentation and what things are like in Australia. But you know, for that, and I agree, we're all rock stars, and I would love the idea of having an international meeting, but I vote for it somewhere warm. Maybe we'll come to you.
Oh, come on.
I know. All right, we'll find somewhere else when this COVID's all over.
Yeah.
But thank you so much again for a wonderful talk. It was, I'm sure we'll have lots of questions and comments are already coming in about everything you've been talking about. So thank you so much. Okay, so with that, I would like to pass over the floor to Michelle Rubin, and welcome, Michelle. Thank you.
Hi, thank you for having me. I don't think you'd want to come to Chicago in the winter, so maybe we won't meet my way in the winter time. All right. Let's see if I can advance my slides up. Yep, here we go. All right, so I'm going to start out a little bit different, but I'm going to talk about how did I become an IBD expert? Like what got me going, what happened? So I actually am a farm girl, so I can relate to the farm person that was there. I started out in Iowa in farm country, and my mother was a medical assistant, and I just admired her all those years. Her parents didn't have enough money to send her to a nursing school, so she was a medical assistant. But I'll tell you what, they did about everything way back in the day. She was delivering babies, she was doing everything. And I so admired her. And so I think she was really a part of my inspiration to become a nurse. I ended up my first job at the University of Chicago. I mean, who'd have known? Sort of like the IBD capital of the world way back. It was a major GI center. And obviously I ended up on the GI floor. I had an option to either go oncology, pediatrics, or GI. And I was like, nah. I think I'm going to try GI. Well, little did I know when I got on the GI floor, 60% of the patients were IBD patients. Believe me, I got nothing in school on IBD. It was a very small amount. So I'm there like, yeah, I knew what colitis was. I had, heard about ulcerative colitis, but the Crohn's and thinking, oh my God, all these people have IBD. Many of them were young then. They were teens. They were in their 20s and 30s. Actually, many of them were the Ashkenazi Jews of European descent. I was like, wait, I'm from Iowa. Where are these people coming from? I didn't even know, that was a major population way back in the day. A lot of them came for referrals for IBS. So we were getting referrals from all over the country. From the rural areas everywhere, all thinking they had IBS. Well, of course, we know much better than that. And we knew that it was not all in their head. It wasn't mental. There was actually inflammatory processes going on there. When we got these patients that would get referred to us, many of them were on mega doses of steroids. Many of them were addicted to narcotics. I mean, I was doing writing down contracts with our patients that were on narcotics because they were going to ERs. They were all being treated with narcotics all the time for their abdominal pain. A lot of them, obviously, we know they were high strung, anxious, depressed, very embarrassed, didn't even want to talk about their symptoms of going to the bathroom and the pain, the chronic diarrhea, etc. And back then we saw very severe patients because we didn't have much for meds back then. We had steroids, azolfidine, just starting to get Azicol when I first started. So we were seeing toxic megacolon 1 to 2 times a week. And I'll tell you, every one of those patients, it happened in the middle of the night and it was urgent surgery. I don't know why, but they all went in the middle of the night. So we also were doing study trials back then on TPN, and that we thought, we found a cure. Bowel rest, that does it. We put them on TPN, bowel rest. We thought that was the cure. Well, we found out that wasn't. But I'm going to tell you, those patients lived with us for 6 months to a year, some of them, because they couldn't go home on TPN, right? There was no home care for this. So they lived with us. These kids were running around with their IV poles everywhere and in their scrubs. And to be honest, we were all like a family. I fell in love with these patients. I had found my passion. These patients, they needed an advocate. They needed somebody to fight for them. And this was it. This was my opportunity that I could find to help make their lives better. Next slide. Then, so I was on the path there on the GI floor. I eventually became the head nurse and the nurse manager. But looking at my mentors, and when I started on that GI floor, Dr. Joseph Kersner, who was a legacy in IBD care in the United States, that was who I was working with in the beginning. And then from there, it was Dr. Stephen Hanauer, who was a fellow. Him and I ran the GI floor back then. So I had some really good physician mentors, but I had some excellent nursing ones too. They weren't IBD specialists though. I had an oncology clinical nurse specialist. That was my mentor as well as my head nurse back then. There weren't those so-called IBD specialists so much running around. But Dr. Kersner had our unit. We were so patient advocate on this unit, very patient-centric, multidisciplinary, collaborative care focus. And he really demanded the best care for his patients back then. We had bidets put in all the bathrooms. Believe it or not, I know you guys in Europe had this. In the United States, we didn't. So this was like huge when we got bidets for the patients. It was like the best thing ever. We had activity therapists on the floor. They were making trivets on Thursdays. Patients would come around because they lived with us, you know, so we had to have a little occupational time for them. Psychiatry was with us, and we had multidisciplinary teams way back when I started. That was so much what Dr. Kersner was promoting, that we had to have the surgeons, the GIs, all the nurses, the psychologists, the physical therapist, social worker, radiologist, pathologist. We had all those team meetings where we would discuss patients. And what I did as the head nurse, I had the nurses present the patients. Usually, you know, you see your residents and all that. Nope. I said, no, our nurses are presenting them. They are here with the patient all day. They know the patient best. They will present the patients. And it went beautifully. It also brought our IBD team nurses together, just made them feel and uplifted them like, I really have a role. I have a place here, and what I say matters. Then moving on, you know, looking at how you need to stretch sometimes in order to move ahead. Well, my first journal publication was in March of 1984, and it was in the Nursing Clinics of North America. Because I was on this IBD floor and with the surgeons and stuff, I sort of you get a reputation of, you know, you're somewhat of an IBD specialist working with these patients. And they asked me if I would do an article on IBD. And of course, at that time, we were looking at using nursing diagnosis and the process. So I wrote one of the articles on that and found out this actually was one of the first comprehensive 80-page booklet that was written on IBD in the beginning. Next page. So from that, I got known, and my first major speaking engagement, I was one to never say no when people asked. I've never spoke to a huge crowd before, but this was in 1985 at one of the SGNA conferences when it was the Society of Gastrointestinal Associates. And I spoke exactly on my article. I mean, it was 150 people out there. Physicians were part of the group. And I was only 7 years in nursing. I thought, what the hell did I get myself into here? But I'll tell you what, I got up there, I did it. And that let me know, hey, I can do this. I can start speaking. That's why you try and push your envelope all the time. Then I went into IBD research on methotrexate, Pentasa, and cyclosporin. I did that for about 3 years. And during that time, I was working on getting my master's. I wanted to get a master's in nursing administration, but also as a clinical nurse specialist. Back then, as an advanced practice nurse, nurse practitioners were really in primary care, and I didn't want primary care. So that's why I chose the clinical nurse specialty route, because I wanted IBD. I knew that was my field. And my first paper in that was on the ileoanal J-pouch patients that had been sort of the love of my patient life when I got into colorectal surgery. So then colorectal surgery, I really got co-authoring a lot of papers. We were doing a lot of research. I wrote a book chapter in the WOCN book, and doing a lot of speaking on surgical nursing and IBD. Then I got certified in 2005 as an SGNA nurse. I needed to have that certification as my clinical nurse specialist. And from there, I joined, got involved in the research committee, looking at researchers' proposals and judging posters. Next. Then I finally found a conference, a place where I belonged, and I got to meet few nurses. This was my first conference I went to, and it was the Crohn's and Colitis Foundation conference that was with advances in IBD at the time. When I first got to that conference, there was probably only 10 nurses total. And I was like super excited. I'm like, I never knew anybody else who loved this as much as I did. I wasn't sure this was really a true specialty everywhere. And so obviously I got involved with the Crohn's and Colitis Foundation. And I can tell you, I think that was my vehicle to moving forward and moving professionally for myself, because it was a vehicle for me to really get involved and do things. And so I ended up getting involved. I actually got asked to be on the National Board of Trustees, and I was on there for 2 terms. And I thought, wow, this was a great opportunity. There's not many nurses, whatever, that were on boards of trustees. And so I took this as a huge responsibility. And I decided I wanted to initiate and get together IBD nurses across the country and get a nurse and advanced practice provider group within the Crohn's and Colitis Foundation. I wanted nursing to have a place on there. We got like 20 nurses all across the country who had the passion I did to work towards setting up guidelines, resources, and educational material for IBD nurses across the country. So I developed that committee, and obviously it's still a standing committee today. My other dream at that time was putting together a IBD APP preceptorship for all the advanced practice nurses out there that we're seeing they are starting to see these patients more and more as providers as well. And this happened probably about 4 years ago, but probably 8 years ago, it was my dream, but it required funding. And thanks to the vendors that help us with all of our initiatives on the Crohn's and Colitis Foundation that help make this a reality. we only had one not one applicant, but we could only take one applicant the first year. And I think we had 10 people that wanted to be a part of it. And now we're up to 15. We had 85 applicants this year. And what they do is they spend 3 days and then ongoing mentoring in a center of IBD excellence. And they actually are with us, on site doing things. And from there, I just went on, I co-authored about 60 IBD publications, become a thought leader more or less, and I participated in multiple local and international projects, and with ECHO also last year, which I'll show you later. Next slide. Just wanted to show you this. This is the discovery of IBD, and as you can see, way back in 1859 was where they were first looking at using the term ulcerative colitis. And that came along earlier, but then Crohn's, the actual using that Crohn's term was the landmark description by Dr. Krohn, Ginsburg, and Oppenheimer in New York. And actually, Dr. Kersner was big friends with this group back then. And of course, he had many stories saying, well, I know they termed it Crohn's, but yet when the physicians were on these articles, they took the name off the first person on there, and that's how it became Crohn's. Otherwise, maybe it could have been Ginsburg or Oppenheimer disease. But anyway, it turned out Crohn's, but there's always a lot of stories behind that. But you can kind of see how things developed, with through the times where you get the surgical treatments emerged in the 1910s, pathological, et cetera, down to the biologics. Next one. And here, and you already kind of saw this, the evolution of IBD therapies. And so you can see, this sort of kind of dictates a little bit how nursing practice is, where we're looking at corticosteroids way in the back, and we were probably looking in the beginning, the moon face and all these side effects that we were trying to point out for steroids in on our patients. And then looking through the meds all the way to now where we are with the biologics, and think about all the drug monitoring we do and looking for antibody levels. And so there's just a lot of monitoring and education that is really advanced for nurses. Next slide. And then if you look at IB treatment goals through the ages, and looking back in 1979, our focus was pretty much on symptom assessment with these patients. And that's how we, when they were having symptoms, that's when they were being treated with medications, et cetera. But now, look where we are now, we're focusing more on objective measures and that treat to target, and looking at the guidelines, the ACG guidelines, looking at disease severity based on disease activity, biomarkers, the endoscopic score. Now we're looking at all of this with our patients. Depression, anxiety, and on the bottom, of course, major role for all of us was education and supportive care throughout time. But the depression, anxiety scales and the emotional effects has really come to light more over the last several years. Next. Here I wanted to start back, looking back through the progression of nurses and what went on. And we already showed you in 1875, ulcerative colitis came about, but that was previously thought as infectious diseases before they actually called it ulcerative colitis. Same with small bowel, that came about in 1932. That was originally thought to be TB before those times. And it wasn't really until 1945 that physicians started working with subspecialties like GI. And this is where the rise of the specialization of nurses came about, in looking at diseases more of the GI tract, focusing, working with our physicians. And I feel like the nurses started working with the physicians and following how they were specializing, and that's how we started specializing. And these nurses attended the ASGE meetings with physicians. They started to network and develop groups. That's where these endoscopy nurses got together and started to organize. The gastroenterological knowledge began to grow, and nurses gained more experience, and they also started to self-organize into specialties. And one of those first organizations was the ostomy nurses, because these ulcerative colitis patients, they got experience with them. And so those nurses were one of the first specialty nurses, as well as GI nursing. And in 1956, which I'm telling you how old I am, it used to be, was the year I was born. Geez, that was when the Crohn's and Colitis, or it was Crohn's and Ileitis Foundation first got started. And that was because of Suzanne Rosenthal, who was diagnosed with Crohn's disease. And at the same time, a 13-year-old Michael Modell, and they were in New York, were struggling with the disease. And the Rosenthals, they were fairly wealthy, and together, the Rosenthals, the Modells, because of their experience with their family member, with Dr. Janowitz back then in New York, founded the National Foundation for Ileitis and Colitis to address education, resources, research, and develop programs for patients. And actually, the first book published for lay people on IBD started with that group. And later on, and it is today, the Crohn's and Colitis Foundation. We know what a wonderful foundation that is today for patients, but also professionals. The initial GI nurse publications were in 1955 to 1965. And they mostly focused on GI disease, ileostomies, and emotional care. In 1964, nurse Elizabeth Katona presented at the American Nurses Association, and her impetus was on ostomy work. 1965 to 1967, nurse Elizabeth Katona wrote about nurse-led clinics that would solidify the domain of nursing in ostomy management, and that eventually evolved into the WOCN organization. In 1965 to 75, journals were published that were authored by surgeons on Crohn's disease when we first started seeing more on that, and nurses were writing on the ileostomies. Next. 1968, SGNA traces its roots to the work of Marna Shermer. She worked in the endoscopy operating room at Mount Sinai in New York. Nurses started attending the ASGE meetings with their physicians, and they started networking. You know, you get us nurses together and we start networking together. We're always anxious to meet others and share ideas and practices. In 1972 and 73, this started the roots of the Sustainable GI Specialty Organization, and GI nursing textbooks began to appear. 1974, the Society of GI Associates, SGA, began in San Francisco. But Crohn's disease information did not really appear until 1975 with Given and Simmons GI textbooks covering various aspects of the disease. And that was in gastroenterology nursing. 1980s, much more started to appear on IBD in the nursing and allied health literature. Carol Butler and Doreen Lyons focused on Crohn's disease and published from 83 to 84. And in 1984 was the Given and Simmons gastroenterology edition, which again covered Crohn's disease. But in 1984, as I told you before, I had published in Nursing Clinics of North America, the first hardcover comprehensive book on IBD. It was 80 pages back then. That was the first comprehensive IBD book out there at the time. And actually, I dug it out recently. I didn't even know this until I was going through all of this and realized, geez, and everything I wrote really is still all about the care of the patient and the symptoms. Next. And then in 1986, SGNA started their certification exam in San Francisco. And in 1989, the SGNA changed to the Society of Gastrointestinal Nurse Associates, an official first publication of gastroenterology nursing. In the 1990s, they had two certifications, one for RNs and one for the associates in SGNA. And around that time, APN started performing flex SIGs in some states that let them perform. So that was some of our advanced practice nurses starting out there. 2007, CBGNA became the American Board for Certified Gastroenterology Nurses. And I wanted to point out, you Canadians, when I was going through all of this in 2009, I was really impressed with this. Lisa Weston, and she may be on, while working towards her master's degree in the Advanced Practice Leadership Program at the University of Victoria, Canada, she wrote that while working with her physicians to develop an advanced practice nurse role in IBD, it was important to articulate an identifiable, distinct level of practice that reflects the education, skill, autonomy, and level of decision-making that encompasses the competencies inherent in that ANP role. So I wanted to point that out because that very much describes where that advanced practice nurse role, what it is about. And then AGA and our other organizations, they started developing, they have an APP fellowship in GI. The Crohn's and Colitis Foundation, as I said, we have a preceptorship and mentorship program. The American College of Colorectal Surgeries, all these organizations now have nurse and APP programs. So organizations now, I think across the country, are pretty much now all inclusive of nurses and APPs. Next. So IBD nurses, historically, they started out really following physician orders and implementing guidelines. That's originally how they started out. Nurses in the beginning had an associate degree and then a BSN degree. The associate degree was just a couple years. It was not as costly as the BSN, so I think that was a good road to start for nurses that didn't have enough money to move into the 4-year level. And the Bachelor of Science in Nursing really became the preferred level because they found that those group of nurses had lower mortality and readmission rates for their patients. But nursing response over time reshaped as nurses closed the gaps in care. They developed specialized areas of expertise. They organized into self-regulating specialty associations and developed certifications. Your ostomy nurses were one of the first ones, and then our GI nurses, the SGNA certification. Their roles we know are vast. I don't need to go into this, but I know telehealth has become a really important role here during this COVID time. Nursing triage, they're wonderful at that. We cannot do without these nurses. They're coordinators. They monitor a lot of blood tests, results. They work in our GI areas. They're procedure nurses. They work in infusion centers. You know, they're about in every area now. And educators, wow. I mean, we can't do without them. They educate on everything, which is so crucial to these patients. Next. And next is the advanced practice nurse roles require a master's or a doctoral degree now. We have a doctoral level nurses. The master's degree was what I went into with the CNS role, but it really established training beyond the RN preparation. The master's level and the doctoral level is really where we are headed in our profession. And over time, I'm sure that those of us who have been practicing for a long time will probably be fathered into that eventually when that becomes mandated here in the United States. And I think over time it will. They're credentialed, APNs are credentialed, they're privileged with their core specialties of the HMPs and narcotic medications, doing assessments, etc. And the specialty ones are more in our specialty areas where they're performing perhaps FLEG-SIGs, doing liver biopsies. Those are the specialty privileges that we can get within our practice. And we have collaborating physicians that we work with. We're not supervised, but we do collaborate with them. However, which I'm going to say down when we get to the evolution of practice here, that in 2019, we started moving toward full practice authority, where we will no longer need to have a collaborating physician, but we have had to have demonstrated 2 years of working with collaborating physician or 400 hours of experience. And we need them to sign off that, yes, we have done this, and then we can get full practice authority. Now, we're not all there in the United States yet. We're just, still moving there, and there is a cost to this as well. But in the evolution in practice, I'm not really going to go through all of that there, but this really started out in 1893 when we're looking at the immigrants that came over to the United States and the nurses that were out there doing home visits. And then the frontier nurses were in the urban and rural areas out there running decentralized clinics on their own. And then in the frontiers in Kentucky, they were carrying narcotics in their bags on horseback. So, you know, we've had early advanced practice back in our history, definitely. But this role really more recently came about when it did come as a need for quality, affordable healthcare, particularly focused in underserved populations. And the Institute of Medicine in 1996 was recognizing that we were having more of an aging population and we were going to be ending up caring for more complex needs. And the hospitals were urged to expand the use of APNs because we were going to be hit with these baby boomers and getting older. And then in 2010, they wanted APNs to work to their full extent of training as projections of a physician shortage. So they knew there was going to be more of a need for providers to fill a lot of these healthcare gaps. Next.
Michelle, so sorry to interrupt. I'm a bit mindful of time. I'm wondering if we could wrap up in a couple minutes just to
I will. I'm going to move quickly through some
so
things.
sorry.
I know we're moving late. And I think what I'll go to is looking at COVID. And I think all of us know how that has changed things a lot in our lifetime here. And a lot of things we all got sort of moved into other areas of practice since our current one shut down. We were doing no surgeries, doing no procedures. But something that really came from this, I think, was billable telehealth visits. We were able to start billing for telehealth, which we hadn't been doing in the past, except our problem is looking at state. Moving ahead. And I'm not going to go through this. It's all there. So you guys will have this for later on, but we are in a Zoom world and it's a new virtual world that has emerged. And to be honest, I feel more tired than ever because I feel like I'm Zooming every day and my day never ends. I am at home, but I go in 3 days a week, but I feel like my work life never ends. Moving on. And how has it impacted us? Everyone was ready, you know, what came from it? Everyone was ready to step up. Teamwork was key, reinforced our mission as this was our calling as nurses, and we did what we had to do. Moving on. This was something that came out of a registry for IBD patients with COVID-19. This is where a group of clinicians across the country actually put input data on all of our COVID-19 patients, looked at practices, and the findings came out: corticosteroids associated with poor outcomes from COVID, and your moderate to severe active disease patients were put at risk due to more severe symptoms of infection. So that was something that came out next. Also, the International Organization for the Study of IBD, and this was a group of 66 IBD experts that got together, published online, and took 76, came up with 76 statements on a consensus of looking at how we treat IBD patients and all the questions that would come in from the practitioner world. They put this out there and published it so that it would give everyone a little okay that, hey, we got you covered. Here's what you need to do. Here are the key issues with COVID. Next. And I'm not going to get into all of this. We can move on. This is just really a lot of the things that I've been doing and what I've been involved in. Move forward. You can kind of keep moving through this, Emily. This is just a lot of stuff just to know that get yourself out there. I never say no to anything whenever there's anything going on. I am right there when it comes to IBD and the nurse's role and the APN role. And I have been involved in so many wonderful projects. Move ahead. Here was the one with ECHO, the UC Narrative Global Advisory Panel. This was probably the most exciting project that I got involved in to meet these wonderful people all across the country. Move it ahead. I'm getting really move, you know. But this was a wonderful project. You can look that up online, talkinguc.com, move ahead. And why that was so wonderful is 6 publications thus far came out of it. There will be more to come. Here was another project looking at disparity in nursing knowledge across the country. And this was the last 2 were ones I was in. This is what I really set up. And actually, I talked to the Canadian group a couple years ago on my APN run clinic. And what my main objective there is that these patients got to be followed. They fall into settling behaviors. They go back to when they had UC, and you can't let them go there. My last slide. Now, tomorrow and into the future, you guys can look at that. But here is my tip slide. Find your passion in what you do, and it will never be a job. I have never had a job. Passion drives your performance and your productivity. You need to do the uncomfortable to move forward, to reach your goals. Find mentors, be willing to learn, and be willing to give back. Strive for excellence, be a team leader, and definitely have a sense of humor and laugh. And lastly, be humble. Be humble. Your actions speak much louder than anything you could ever say and do. Thank you.
Thank you so much, Michelle. What an inspirational talk. And I know you took a lot of our audience back to some of the early days of IBD nursing. They sure enjoyed reminiscing with you about some of the ways that we used to take care of IBD patients.
Yeah.
Yes, so I think
Did my age away, didn't I? Damn it.
Memory lane, I think. So, thank you so much for your talk.
Yeah, thank you.
So next, we do have a little bit of time here for questions. So I just wanted to remind everyone to type their questions into the chat box. Thank you to those that have done it throughout the presentations here. Just to remind you, we heard from Kelly and from Nova Scotia. We got to hear all about her urgent access clinics, the nurse navigator role, and all about her virtual care and how they've adapted to the COVID environment. Then, of course, we were so lucky to hear from Palle and the European perspective and all about NECO and interesting challenges that are different than what we see in Canada, including like having to navigate through many different languages. So that was really interesting. And then Heidi from Australia, what a great talk. And we've already had lots of questions and curious people about her pregnancy pathway program. And of course, that research that she did showing how nurses really decreased the length of stay and decreased admissions. What a great message to leaders that we need more nurses and the value of that in the healthcare system. And then finally with Michelle, walking us through the role of the IBD nurse in the US. So thank you so much. Now with that, I do have some questions. I would like to start with a question that came in from Kate Lee, so of course from Crohn's and Colitis Canada. And this was a question for Kelly. And she was asking, would you attribute the decrease in wait times in 2020 directly to a shift in virtual care? I don't know if Kelly can
I can. Yeah, I can hear. I think that probably virtual care was a part of it, but I don't think it was the only factor that helped us. I think there was a certain amount of coming together as a team and focusing on what was important and getting it done when COVID hit. And I think some of that was probably why we had a decrease in our wait time for triage patients. We really focused and we got it done. And somehow all the other stuff, was put aside for a period of time, and we focused on that patient care aspect of it. And I think that's why in some ways we did things better.
Yeah, it's kind of a silver lining sometimes.
It is, it can be, yeah.
Yeah. Thank you. So I also have a question for Heidi, and this one is from Barbara, or at least to get a little bit more of an idea around the concept and the idea of your youth health center. And she wondered, Barbara's from Halifax, and she wondered if you could speak to the evolution of that center further and describe how it works from a referral point of view. And she wondered, does that center focus on youth with chronic diseases? And just to give you some perspective, because in Canada, our healthcare here, they're considered pediatric until about the age of 17 or 18. And then they sort of age out of pediatrics. And with that, they often have a shift in their private insurance whereby they are not always covered under a parent's insurance health plan unless they're usually in like a post-secondary education. And so if that's the case, they're kind of covered up to the age of 25. But she just wondered about access to clinical health psychology, particularly because that is a definite challenge in Canada, especially in that age group, and wondered if that was incorporated in your center as well. Sorry, Heidi, we got to get your mic on.
I'm unmuted now. Sorry, I put my uniform on. I'm going to go and do an afternoon shift, go to MDT in the afternoon. So basically what happened was we had this massive children's hospital that was planted right beside us. And we became the area where once children became young people, they needed to transition into the adult service. That service is completely inundated because it takes referrals from all over the state. Now, when those kids get towards the age of 18, they have to leave. They will not be seen if they enter that emergency department. Once upon a time, they would continue seeing those young people up until about the age of 20, 21, but they just didn't have capacity to go ahead and do that. I'm not sure what your public health system looks like, but we are a private hospital where I work that provides a public service. So everything is free. Those kids come through our doors and, well, those young people, they come to us. They don't like to be called kids, obviously. And we'll take them as young as 16. To be honest, if they're 16 and they get a diagnosis, they might come directly to us. Most of our clinics are, as you say, for chronic disease. So we have the Queensland Diabetes Centre, so loads of young people with diabetes. We have the rheumatoid clinics, we have cystic fibrosis, and it is to look after young adults, as I said, from 16 to 29, and they're allowed to stay within that young adult space. Within that clinic, we have a dietitian, we have a psychologist, we have a social worker, and as I said before, we screen the patients every single visit to see how they're doing nutritionally and as far as their mental health goes. Then we have the young adult support unit, and they're genuinely a support unit. So what that means is that we have all of those allied health people who get together and discuss those patients individually. So we will have the psychiatrist, the psychologist, the psychiatric nurse who will discuss specific patients, and we'll even introduce the patients to those healthcare providers when they do transition at the beginning if we think they need to as well. So those practitioners will also see the patients when they're inpatients. We have a young adult inpatient ward for those with chronic disease, and those are the specialties that I've outlined as well. But that will also include young adult gynecology if they're coming across and they're really young. We will take them even younger, as young as 12, if it's a specific gynecology issue that is inappropriate to be treated at the Children's Hospital. So we are incredibly lucky, and part of the reason that I put together the screening framework for those young people when they come to our service is because I had to prove that we used it. If you don't use it, you're gonna lose it. And we've done incredibly well with being able to prove that and show the outcomes. The other thing, as a side note to that, is that we have a young adult space for emotional health for inpatients. So they will have group work and they will have psychiatrists. It's an inpatient psych unit, but for low to mid-level conditions. It's not a lockup unit. So, I mean, it's an absolutely amazing resource. One of the programs that they run at the moment it's called the Recovery College. It's called Recovery College, and it's for young people who are in their final years of high school and first years of university, and they're just wigging out. So it really teaches them ways that they can learn coping mechanisms and good life skills for the rest of their life. In addition to that, we even have dietitians who will go in and teach these young people how to cook, because I don't know how many young people, you've seen the young people's diets these days. So many people living on loaves of white bread, especially if they're living independent of their parents. So it's an absolutely amazing resource. And yes, for young adults with chronic disease.
Thank you so much for that. That's a great overview. It gives us a good idea of kind of what you see there and all the services you offer. So thank you so much. I think we may have time for one more question here. And actually this one was from one of our pediatric colleagues. I have to represent pediatrics here tonight too. And Karen, this one can be, it's actually to any of our panelists, but perhaps I'll ask Palle for the international perspective first. And it's just reflecting back on the last few decades. What do you hope to see in the next 2 decades in IBD nursing? So realistically and a wish list. So I wondered if I could ask Palle first, and then maybe Kelly to get the Canadian perspective as well.
Well, I think, as we saw in most of the presentation, especially the last one, I think there's been a development in the treatment and the care of IBD nursing. So I think if we can achieve the IBD standards or the consensus, NECO consensus statements in every single IBD center, I think being an IBD patient is I think we can meet their most of the needs for the IBD patients. So I think the challenge is to achieve this standard that has been described already. So I hope that is what we're going to achieve in the next couple of years. Yeah.
Thank you. Thank you so much. And Kelly, if you're still on, kind of the same question, you know, what do you hope to see in the next 2 decades for Canadian IBD?
Sorry about that, I was muted. But so in Canada, we have developed IBD centers of excellence across the country, and that's wonderful. And all of those centers of excellence are supposed to include nursing care, and that's wonderful as well. But because we're such a large country and we have so many rural communities and we have so many small community hospitals, I worry about the lack of nursing care for IBD patients in those areas. So for example, where you would have a standalone gastroenterologist who's seeing patients in clinic with no nursing care at all, I worry about, you know, us expanding into those areas. And I just did a mentorship with Nicole from Mountain, and she's doing exactly what I think we have to encourage. So she's working herself as a nurse with an individual gastroenterologist, and she's providing the nursing role. And that's the type of I think, growth that we have to consider now in Canada, and that's where we need to move forward.
Thank you. And, you know, just a huge thank you to all of our panelists tonight. I think in the interest of time, I will conclude the question session here. And just again, a huge thanks to our panelists and to our entire audience tonight for your attention. And with that, I'd like to hand over to Kate Lee from the Crohn's and Colitis Canada for some exciting news.
I guess I should unmute myself. Okay, thanks, Melanie. I have to thank all the speakers. That was those were fascinating historical perspective on the evolution of nurses. I don't have a nursing background, so I was just amazed at all the contributions of the nurses and how proactive you've all been in evolving the IBD nursing care. So thank you for that. I have the honor tonight of presenting the 2020 Outstanding Nurse of the Year Award. This award recognizes a nurse who has made exceptional contributions to the clinical care of patients with Crohn's disease or ulcerative colitis. It celebrates a new nurse who has displayed an ongoing commitment to their patients, serving as both nurse and patient advocate. The nominations were adjudicated this year by a panel of patients. And the 2020 IBD Nurse of the Year goes to, drum roll please, Krista Yuso, a pediatric IBD education and support nurse at the Hospital for Sick Children in Toronto. Before we ask Krista to just wave and say hi so everyone can see her on her webcam, I just wanted to review some of the comments that were in the nominations forms. That really speaks to why Krista was selected by the selection panel, which were patients. So let me start. So these are some of the excerpts. Krista nurtures her young patients as if they were her own children. She guides parents. She mentors more junior nurses who themselves have blossomed into the role of IBD clinic nurses. She teaches pediatric gastroenterologists in training about pediatric IBD, and she mothers and encourages us all. Krista is the glue of the IBD multidisciplinary team at Sick Kids. A patient of Krista, who also wrote a lovely nomination letter, indicated, since the beginning of my journey as a patient at Sick Kids, Krista was there every single step of the way. She allowed me to view Sick Kids as more than walls, medical equipment, doctors, and beds, but instead to see a support system, an IBD family, a positive outlook, and above all, a healthy future. Krista has the most beautiful soul of anyone I have ever met. Her amazing smile, her contagious laugh, and her kind words make Sick Kids feel like a place where you belong. There is not a single instance in which I can remember where I had an important appointment that Krista was not there for. Krista would never seek an accolade or award like this. Her rewards are in knowing the difference she makes in young patients. So with that, please join me. And I'm hoping that everyone can turn their webcams on. I know most of us had it off so that the webcam could be focused on the speaker, but I'm not the central point for this. It's Krista. Krista, can you say hello so everyone
Certainly
sees you?
can. Thank you very much, everybody. It is quite a large honor.
Wonderful. So if everyone can just join me in
Congratulations.
congratulating her. Congratulations, Krista.
Woohoo! Congratulations, Krista.
Thank you.
Very well deserved.
Thank you.
You
You're
deserve
a
it.
rock star, Krista.
Krista, I'm videotaping for you, but congratulations.
Thanks, workplace.
And Krista, I had the honor of getting to know you a little bit at the kids camp, I believe. And so it was lovely getting to know you, and very well deserved. So congratulations.
Thank you very much.
Okay, so I think, Jen, do I hand it over to you now? And is this prize time?
Yes, this is great.
Okay.
And just before I move on, congratulations, Krista. Very well done, very well deserved. Before wrapping up tonight's program, though, I would like to extend a very special thank you to our moderator this evening, Melanie Watson, along with our rock star speakers, Kelly, Palle, Heidi, and Michelle. Thank you so much for sharing with us your experiences and insight into IBD nursing. Before tonight, I really thought I would see so many differences amongst us, but to be honest, it was really nice to see how similar we actually are. I'd also like to again thank our sponsors, AbbVie, Pfizer, and Takeda, for their generous support, not only for tonight's program, but for IBD nursing in Canada. I cannot forget to thank our important partners at Crohn's Colitis Canada, especially Kate Lee and Emily Criddle for their commitment and so much enthusiasm towards CANIBD. Thank you so much. And finally, a big thank you to all of you for joining tonight's program. You will be receiving an evaluation by email shortly. So we really hope that you will take some time to complete that and share your thoughts with us about your program. But before I leave, we do have a giveaway. Because we couldn't get together this evening, we decided that we would do a little bit of a raffle. So we have all of your names in our hat here for all of the nurses who attended tonight's program. And we're going to be giving away 3 copies of Inflammatory Bowel Disease Nursing Manual. And it was nice to see that Usha Chauhan, a CANIBD nurse, was one of the co-authors on one of the chapters within this book. So congratulations, Usha, for that. So anyway, I'm going to choose, drum roll, please. The first one is to Mary Morgan. Yay, Mary.
Thank you. Very exciting.
And the second one will be, oh, Krista, this is like your totally lucky day. Krista, you also received not only the CANIBD your award, you also get a copy of Inflammatory Bowel Disease Nursing.
Yay.
And finally, Ashley Cruden.
Yay.
Ashley, yay! So what we're going to do is we're going to obtain these books and have them mailed directly to you. So you will probably hear from one of us shortly to get your details. So congratulations.
Thanks, Jen.
So thank you again to everybody for joining tonight. We hope you enjoyed the program. We ask that you stay tuned to your email for further CANIBD webinars that are going to be taking place in the new year. If you have any ideas that you want to share for future topics, please reach out to us. Take care. Have a good night, everyone.
Jennifer,
oh, yes?
Interrupt you just for 2 seconds. We need to say a big thank you to Jennifer for everything she's done organizing this evening. So Jennifer, thank you and congrats on a great program. So
great.
Thanks
you.
for that reminder, Emily.
Thanks, Jen.
Thank
You're
you.
also a rock star.
Put you on the spot.
Thank you.
Thank you.
Have a great night, everybody. We'll talk to you again soon.
Bye-bye.
Thank you very much. Bye-bye.
Everybody.
Have a good night.